Thank you for having me speak today. I'm honored to be participating in this conference. I'd like to speak a little bit about big data implications for brain tumor research using the National Stereotactic Radiosurgical Registry. As a disclosure, I am a member of the NeuroPoint Alliance board. Stereotactic radiosurgery is an established discipline. There are more than 2 million patients that have been treated worldwide. It's a multi-billion-dollar industry, and there are more than 800 centers throughout the world that deliver radiosurgery. If you look at the level of evidence in radiosurgery, there are largely single-center retrospective studies. There are patient archives at major academic radiosurgical centers, such as the one shown here at our center, containing charts and films from decades of treatment. The evidence that's in the literature is largely level 3 or lower evidence. There are certainly some opportunities. The International Radiosurgery Research Foundation offers the opportunities to do multi-center retrospective and prospective studies. But if you look at some of the earliest literature published in radiosurgery, this by a colleague of mine, Dr. Steiner, this important paper on the use of radiosurgery for AVMs was a single patient with 19 months of follow-up. Certainly, we can do better and should do better in our evidence that we're publishing. The randomized controlled trial is the gold standard for evidence in the literature. It was first introduced by Charles Sanders Peirce in the field of psychology. That really constitutes level 1 or level 2 evidence. The challenges, of course, with randomized control trials are the differences in clinical equipoise, crossover ethics, time involved, the cost for doing such a study, and the challenges of doing them in a field such as neurosurgery, where the indications may be much more narrow and the incidence of disease much more rare. So let's just look a little bit at the idea of doing a randomized control trial for brain metastasis using radiosurgery, whole brain radiation therapy, stereotactic radiotherapy, and surgery. Some of the confounding factors are listed here, and some of the endpoints that one could do beyond survival include neurocognitive function, recurrence of tumor, patient satisfaction, and cost. This number of permutations looking at these different treatment modalities would make up a grid that would require 72 different comparative studies, or RCTs. So let's just look at one of those studies. This study by Eric Chang, published in Lancet Oncology, took nearly 7 years to accrue 90 patients to determine that radiosurgery provided better neurocognitive outcomes in patients with 1 to 3 brain metastases than patients who underwent similar treatment with whole brain radiation therapy. As you can see, the challenges of obtaining such data for 72 different comparators would be incredibly difficult. How long would it take us to look at all these different permutations? What would happen as the technology advances and invalidates the earlier results? What happens when we look at permutations associated with other things such as immunotherapy and targeted therapy, which makes it even more complex? How can we better get the information we need as clinicians? So we constructed the concept of a prospective registry, and so have others. Prospective registries have been used by groups such as Yamamoto, who published also in Lancet Oncology, in a real-world prospectively collected registry-based data looking at patients with 1 to 10 brain metastases treated with radiosurgery. The National Radiosurgery Registry is comprised of more than 23 different sites throughout the country, both academic and private. The goals of the Radiosurgical Registry really were to collect and analyze medical data and to gather this radiosurgical treatment data across the U.S. and to establish national benchmarks for quality, and then to look at outcomes in the basis of clinical outcomes, individual differences in morbidity and mortality, and the cost effectiveness of radiosurgery. The process of entering data in the radiosurgery registry is shown here. Clinical data and clinical assessments are uploaded along with imaging data. That these reports are uploaded into the cloud using a common software platform. Reports can be generated and data can be exported for post hoc retrospective analyses. The data upload involves both clinical and imaging data. We minimize the manual data entry, and on any single encounter there are no more than 25 manually entered fields. And then you can see here how the targets, for instance tumors, may be linked from the initial planning radiosurgery studies to subsequent follow-up studies, thereby allowing for a greater uniformity of data analysis and particularly outcomes for tumors. And then you can see the drop-down menus shown here for uploading of the clinical information, such that there would be some consistency to the data dictionary used by all sites. You can also generate your own analysis for patients, either on an individual basis for an individual patient or across aggregates of patients that you're treating. And that's shown here, some of the tumor changes and tumor volume changes as a function of time. This would allow you to analyze your data in a prospective fashion and to be able to do practice improvement. And it also encourages broad research participation across the radiosurgery group. So thus far, we've had thousands of patients entered in the radiosurgery registry, as is shown here, more than 6,000 events and more than 3,000 unique patients. Each patient has a diagnosis code. As you can see here, the vast majority of them are metastatic in nature, but we also included meningiomas, AVMs, glial tumors, pituitary adenomas, and other nerve sheath tumors such as acoustic neuromas. When we look at our outcomes for brain metastasis, these are pretty consistent with what we're seeing across the both prospective as well as retrospective studies. Median survival at 12 months for brain metastasis patients in a radiosurgical treated cohort were 68%. And certainly we observed that the RPA scoring system, when applied to our radiosurgery registry cohort of brain metastasis patients, very closely mirrored other outcomes, with RPA class 1 providing better survival and RPA class 3 showing worse survival. So what are some of the predictors of survival for radiosurgery treated brain metastasis patients? We did a Cox regression analysis across hundreds of patients that were accrued to the radiosurgical registry. The things that predicted better survival were systemic disease control and RPA score. Interestingly, we did not see predictors of overall improved survival with immunotherapy, whole brain radiation therapy, or surgical resection, at least not in the cohort analyzed thus far, although we're accruing patients with each passing day. More and more patients are accrued onto the radiosurgical registry. Over the years, we've been able to publish several manuscripts. These are just two, one describing on the left here the inception of the radiosurgical registry, and then the other one looking at outcomes for brain metastasis patients. Additional studies are underway looking at brain metastasis patients with help with the Mayo Clinic Big Data group. So in conclusion, the NeuroPoint Alliance Radiosurgery Registry helps to capture patient characteristics, processes, and outcomes of care. Big data will help to allow us to define better the quality of outcomes achieved with radiosurgery, to better allow for practice improvement, to help with filling competency gaps, and to drive high-quality research in an era where single-center retrospective studies were not likely to move the needle and advance the field as much as big data studies would. This approach is likely to help to advance the field in more or different meaningful ways than randomized controlled trials alone. Thank you very much for having me speak today. I hope that this talk provides some answers for you about the implications of big data in the field of radiosurgery.